A warm welcome to everyone to the anesthesia classes. The topic that we are going to cover today is neuromuscular blocking agents. Now, before we start with the neuromuscular blocking agents, let's have a brief review of the neuromuscular junction that actually these blocking agents are going to block. See, what happens is that when the nerve impulse comes, an action potential is generated. Because of that action potential, we have a pathway that is activated, which consists of cyclic AMP, which changes into AMP, and eventually calcium ion is released into the axonic terminals. And this is the calcium ion that is going to play a lot of role in the nerve conduction. See, in this figure, we have the axon terminal. This is the muscle membrane, and between them is a synaptic cleft. The diameter of the synaptic cleft is around 20 to 30 nanometers. Now, as soon as the nerve action potential comes, there is entry of the calcium through the calcium gated channels, and this calcium is now going to act on the vesicles. They are acetylcholine vesicles which are present in the axon terminals, and this acetylcholine vesicles have around thousands of acetylcholine molecules in them. When this calcium is going to join these vesicles, it activates some special proteins which are synaptobrevin and synaptotaxin protein, which are now going to let these vesicles join this membrane. And eventually we have exocytosis, and all the acetylcholine is released in the synaptic cleft. And this acetylcholine is now going to act on the receptors which are present on the muscle end plate, which are the acetylcholine receptors. The beauty of these acetylcholine receptors is it is a pentameric receptor. Please remember, it's a pentameric receptor which consists of two alpha units, gamma, epsilon, and delta. This is what makes the pentameric receptors. And generally, the acetylcholine is going to act on the alpha subunit of this receptor, and eventually the nerve conduction impulse is propagated from the nerves to the muscle fibers, and a muscle action potential is thus generated. The other name for the acetylcholine vesicles which are released are photons, because a lot of acetylcholine receptors are released. And the final metabolism of this acetylcholine, which is released in the synaptic cleft, is done via the acetylcholine esterase enzyme, which is present in the synaptic cleft itself. Thus, the half-life of this acetylcholine molecule is a few seconds only. Now, talking about the neuromuscular agents, if you all remember from the history of anesthesia class, Harold Griffith was the person who gave the first muscle relaxant, which was D-tuberculare. Please remember this. The first muscle relaxant to be introduced was D-tuberculare. It was a arrow poison which was used by the hunters to kill the animals. It's an arrow poison. The skeletal muscle relaxants are further divided into two types. One are the depolarizing blockers, and the second are the non-depolarizing blockers. When we talk about the depolarizing blockers, the most commonly used depolarizing agent is succinylcholine, also known by the name of decamethonium or suxamethonium. And when we talk about the reversal, generally scoline does not need a reversal, but these days a recently introduced reversal for the scoline has been there, which is calabadoin or WP6. This is a recently introduced thing, but not used practically these days even, because scoline, I'll tell you further, can be metabolized by using a physiological esterases. So the reversal agent recently introduces calabodin. When we talk about the non-depolarizing muscles, the non-depolarizing muscle relaxants are further divided into three categories. One, aminosteroids, benzyl isoquinolones, and the latest one, chlorofumarates. The benzyl isoquinolones consist of your etracurium, cis-etracurium, mivacurium, and doxacurium. The D-tubocurarine, which was the very first skeletal muscle relaxant to be introduced, also belonged to benzyl isoquinol group. The reversal agents for this group are sugamadex, neostigmin, or Hoffman degradation. We'll be coming to this one by one. It's just the brief introduction and then we'll summarize it at the end too. Aminosteroids are vecuronium, pancuronium, rocuronium, pepicuronium, and the historically introduced one, rapacuronium. The reversals are neostigmin, sugamadex, and calabodin. The recently introduced are chlorofumarates diesters, which are gantacurium. Gantacurium is also known by AW4304 and this number is asked too. The Gantacurium is also known by one number, that is AW4304. The reversal agent for Gantacurium is L-cysteine degradation. Now moving forwards first with depolarization and non-depolarizing agents. Before we come to one agent by one, let's see the mechanism of action of these drugs. See, as the name suggests, the depolarization muscle relaxants. These relaxants are agonists. Just remember this. Your scolen are agonist. They act on your nicotinic acetylcholine receptors like any acetylcholine. Generally, these receptors have pentameric structures on which the scolen, which is nothing but diacetyl, and they go and join this acetylcholine receptors and act like a agonist, producing depolarization. And as soon as the depolarization occurs, what happens is, yes, fasciculations and twitchings take place because it is depolarization. But then how come it causes paralysis? What happens is that there is a consistent and a sustained depolarization of the muscle membrane, and eventually there is no repolarization state only that comes. And when there is no repolarization state, then eventually your muscle gets into fatigue and you have flaccid paralysis. So remember, the depolarizing agents are agonist agents, non-competitive in nature. They lead to depolarization, which can be seen in the form of fasciculations and twitchings, and eventually leading to no repolarizations and flaccid paralysis. This is depolarization. These are the agonist. They will open the channels. The sodium channels which are open, they are open and eventually depolarization takes place. Now what happens in non-depolarizing agents? Your non-depolarizing agents are competitive agonists. They are competitive antagonists. And because of being competitive antagonists, they are not allowing your acetylcholine to act on the receptors. They come, they sit on the receptor. Your acetylcholine is not allowed to sit on the receptor, and eventually what you get is paralysis because acetylcholine cannot pass the action potential from the nerves to the muscles. But one thing more important about non-depolarizing agent is that suppose this is the axon terminal, this is your muscle membrane, right? Some receptors are present presynaptically also, and most of the receptors of acetylcholine are present postsynaptically. Your non-depolarizing muscle relaxants are going to act also on your presynaptic receptors. What was the function of these presynaptic receptors? These presynaptic receptors were also responsible to increase the release of your acetylcholine. And eventually what happens is, in depolarizing muscle relaxant, what happens, they're always of shorter duration of action. And depolarizing muscle relaxants are not going to act on the presynaptic receptors. Whereas non-depolarizing are going to act on the presynaptic receptors also, and they are going to not only compete with the acetylcholine for that receptor, but also they won't allow the acetylcholine to get released from the nerve terminal. Thus, they have a dual action. One, not allowing it to work on the receptor. Second, not allowing it to come out of the axon terminal also. That is your non-depolarizing muscle relaxants. I repeat, this difference is very important to understand. Depolarizing muscle relaxants, they are non-competitive agonists. They act on the receptor, leading to normal depolarization, which is sustained. No repolarization happens, and eventually flaccid paralysis can be seen. Whereas the non-depolarizing muscle relaxants, they are competitive antagonists. They act on the receptors. They don't allow the acetylcholine to come and sit on the receptors. First. Second, they're also going to act presynaptically and not allowing the acetylcholine to get released further, and thus causing paralysis. Now, one more thing about the depolarizing muscle relaxant is the phase 2 block. I told you that depolarizing muscle relaxants have two types of blocks. One is phase 1 block. The phase 1 block is nothing but the depolarization state, whereas phase 2 block is known by the name of desensitization state, in which your receptors become desensitized and your depolarization muscle relaxant is now going to act like non-depolarizing muscle relaxant. And all the clinical features that are going to come now are of the NDMRs. For example, like we have already discussed in the neuromuscular monitoring class, for example, your tetanus, your post-tetanic count, your train of 4. No fade phenomena was seen in the depolarizing agents. But in the phase 2 block, all such phenomena which were applicable to the non-depolarizing muscle relaxants will now be seen in the depolarizing agents also. That is your fade phenomena. The fade phenomena, what is the mechanism of the fade phenomena? The mechanism of the fade phenomena is that presynaptic vesicles or the presynaptic receptors which were stopped by the non-depolarizing agents. And eventually when the phase 2 block comes, all the drugs are now going to act in the similar manner. Now moving towards one drug at one time. I hope the neuromuscular junction, the main differences between the depolarizing agents, the mechanism of action, the non-depolarizing agents and the phase 2 block are clear. Now moving to scolin, I'll repeat, scolin is a depolarizing agent which is a non-competitive agonist acting via depolarization. Eventually there is no repolarization and we get a flaccid paralysis. The structure of scolin is diacetyl. It has two acetyl groups attached to each other. Talking about the onset and duration, it is the fastest acting and duration of action is also the smallest. It is fast acting with shorter duration of action. The beauty of scolin is that it has narrowest onset variability. Narrowest onset variability means because of that fast acting and shorter duration of action, what happens is in a patient who has been pre-oxygenated, and suppose you have given scolin in such a patient, it has been seen even if a muscle relaxant has been given to the patient, but this patient is not going to die of hypoxia in case you are not able to ventilate the patient. This is the beauty of scolin, and yes, an MCQ for you all too. If we are talking about one safe muscle relaxant agent which can be given in the cases of difficult intubation or anticipated difficult intubation, scolin is the choice of the drug because the onset is fast but the duration of action is also very short. The duration of action of scolin is just 3 to 5 minutes. And if you all remember, your brain cells can withstand hypoxia for around 8 minutes. Thus, the action of scolin wanes off. Patient regains its own respiration without getting hypoxic. The onset is just 30 to 60 seconds. I hope now you remember this. Please always remember the drug of choice in difficult intubations is your scolin because of its shorter duration of action, and the patient is not going to die of hypoxia if scolin is given to that patient. Now talking about the dose of the scolin. See, scolin is a water soluble agent. Okay, a water soluble agent which is metabolized very fast. That is why scolin is always given by total body weight. Generally, most of the anesthetic drugs these days are given by the idle body weight, but scolin always have to be introduced or given in the body via using your total body weight of around 1.5 to 2 mg per kg, with children having a little higher dose because of the increase in the volume of distribution of the children, and the BMR is also high in comparison to the adults. Talking about the refrigeration part, scolin can be refrigerated at 2 to 4 degrees Celsius for 2 years. And talking about the room temperature, it can be stored for 6 months. I repeat again, the agent of choice for difficult intubations is scolin. For emergency surgeries, the preferred agent of choice is again scolin. Now talking about one more indication of scolin is your RSI, that is your rapid sequence intubation. If you talk about rapid sequence intubation without a difficult airway anticipated, then the drug of choice is rocuronium. The drug of choice is rocuronium in RSI if no difficult intubation is anticipated. But if difficult intubation is anticipated, then the drug of choice in RSI is scolin. Now, what is RSI? Let's have a brief of what actually RSI is. See, rapid sequence intubation, yeah, a lot of questions come on this also. It is generally a case-based question that comes on rapid sequence intubations. When we talk about RSI, it is generally done in those patients who are considered like a full stomach patients and they are at very high risk of aspiration. So in these patients, what is avoided is positive pressure ventilation. The positive pressure ventilation is avoided in patients who are posted for RSI considering their full stomach and they are at high risk of aspiration. So what actually we do is, when we have started giving our induction agent, we give a cricoid pressure to these patients. What is given is a cricoid pressure. If you all remember from your anatomy classes, cricoid is a ring of laryngeal cartilage, which is a complete ring, right? This is the main reason why cricoid has been selected to giving a pressure during your RSI, because it's a complete ring structure. Around 30 newtons of pressure is given on your cricoid cartilage, which obstructs or obscures your esophagus and thus prevents the aspiration of the food particles into your airway. This is the phenomena behind giving your cricoid pressure. Okay, and the cricoid pressure is given when you start giving your intravenous induction agent, and when you remove your cricoid pressure, please always remember the cricoid pressure is removed when you have inflated the cuff of your endotracheal tube. Only then you have to remove your pressure. This is the story behind your cricoid pressure. Now the star question for the cricoid pressure is, what is the bony structure against which this cricoid pressure is given? It is given against your cervical vertebra. Your cricoid pressure is given against the cervical vertebra that is used to obscure your esophagus. The drug of choice, rocuronium, but if difficult intubation, then for RSI, the drug of choice is scolin. The drug of choice is rocuronium or scolin based on the fact that they have a faster onset of action. These patients are pre-oxygenated, but we avoid positive pressure ventilation in these patients. Thus, the reason of choosing the drug is the faster onset of action, that is your around 30 to 60 seconds. Now the metabolism. Scolin is metabolized by an enzyme which is known by the name of pseudocholine esterase. As I've already told you when we were talking about the NMJ junction, acetylcholine was being metabolized by an enzyme known as the acetylcholine esterases, and scolin is metabolized by an enzyme which is produced by liver and generally found in your plasma. Please remember, your pseudocholine esterase, also known by the name of butyrylcholine esterase, is found in plasma and not your cleft. Okay, in the cleft you can have acetylcholine esterase enzyme, but not the pseudocholine esterase or butyrylcholine esterase. Now the star question which comes here is, this is the reason why bolus of scolin is given. Scolin is one of the drugs which is given in the bolus form, because if you're giving the scolin very slowly, then most of the scolin will get metabolized in the plasma itself because of the presence of pseudocholine esterase. That is why scolin is always given by bolus with a flush. Okay, let's add one thing to it. Should we? Yeah. One other drug which is given by the bolus form because it gets rapidly metabolized by the esterases of your body is your adenosine. Please always remember, there are very less drugs in anesthesia which are given in bolus forms. One of them is scolin and one of them is another antiarrhythmic drug, that is your adenosine. Yes, it's for SVT. Good. We have no active metabolite of scolin. Excretion is generally renal and it mimics the action of acetylcholine. What happens in scolin actually is that it acts on your sodium channels, and which sodium channel it acts on? We have two types of sodium channel actually. One are voltage gated sodium channels and other are time gated sodium channels. And acetylcholine leads to sustained depolarization followed by closure of your time gated sodium channels, which lead to your flaccid paralysis eventually. I told you, first we have fasciculations because of the depolarization, followed by the closure of your sodium channels. Which type of sodium channels? Time gated sodium channels, followed by your muscle paralysis. Okay. In a condition known as myasthenia gravis, which is an autoimmune condition, people are resistant to scolin. This is a very important concept to remember, that in myasthenia gravis patients are resistant to the effects of scolin. Now, when we talk about scolen, there are certain things that we have to keep in mind. Is the first, there are certain factors that can lead to prolongation of the effects of succinylcholine. The first is decreased concentration of your enzyme pseudocholine esterase. I already told you that pseudocholine esterase is produced in the liver. So anything that is going to lead to a liver failure can eventually lead to decreased concentration or activity of your pseudocholine esterase enzyme, leading to prolonged action of your scolen. So first is liver disease. Second most important is pregnancy. In pregnancy, we have decreased activity of pseudocholine esterase. That is why the dose of scolen is decreased in pregnancy. This is an assertion reason question which comes that in pregnancy the dose of scolen is decreased. The reason is because the activity of pseudocholine esterase is decreased. Then we have organophosphorus poisoning. The old age, in old age also physiologically the concentration of the pseudocholine esterase decreases. Then burns, renal failure and malnutrition. These are all the conditions. Of course, you have to memorize, you have to read, you have to revise again and again to get used to the conditions which can lead to decrease in the activity of pseudocholine esterase. But if we have to go it by a easy way, it is like liver, renal failure, malnutrition, any special scenarios like old age, burns, pregnancy. Everything is going to lead to decreased activity of pseudocholine esterases. Yes, there's a list of drugs that can lead to decreased activity. Out of this, the most important drugs I'll tell you about is the first, neostigmin. Neostigmin is your reversal agent. We'll come over to it. This leads to decrease in the activity of pseudocholine esterase and promotes the activity of scolen. Now, this is one more difference between the depolarization and non-depolarizing agent is the depolarizing agent, as I already told, the reversal is not by neostigmin, whereas the non-depolarizing agents get reversed by neostigmin, whereas scolen will get potentiated by neostigmin. Then your metoclopramide, that is the prokinetic drug, beta blockers, your non-depolarizing muscle relaxants, they are also going to get decrease the action of pseudocholine esterases, oral contraceptive pills, and certain cytotoxic drugs. Most important to remember is your neostigmin. It potentiates the action of scolen. Prokinetics, antiemetics, they potentiate the action of scolen by decreasing the activity of pseudocholine esterase enzyme. Now, there is a genetic variance that can lead to the decrease in the activity of the pseudocholine esterase, and that is denoted by the name of Deboucain number, which is extremely important. This Deboucain is nothing but a local anesthetic, a amide local anesthetic, which acts on or it inhibits normal pseudocholine esterase. Okay, it inhibits the activity of normal pseudocholine esterases, and the normal Deboucain number in our body is 70 to 80. Sometimes the enzyme on which this Deboucain number or this genetic variance is present is chromosome 3 at Q27, and yes, this has been asked once, that the atypical pseudocholine esterase enzyme, where is the chromosome, this genetic variance actually present, that is chromosome number 3. When you have atypical pseudocholine esterase, it's a qualitative defect in the body and not quantitative defect. This qualitative analysis is done by using your Deboucain. In atypical pseudocholine esterase, the Deboucain number decreases to 20. I already told you, Deboucain is responsible for inhibiting your normal pseudocholine esterase enzyme, And if the body has atypical pseudocholine esterase, dipyquine is not able to inhibit it and the number decreases. If you have typical, the number is 80. If there is heterozygous, it is 40 to 60 number, and there is prolongation in the activity or the duration of action of scolin by 50 to 100%. Let's say, for example, they say the duration of action of scolin is around 3 to 5 minutes, so it will increase to 20 to 30 minutes. But if it is homozygous atypical, the Debye number is only 20 and the effect is prolonged by 4 to 8 hours. Now, what the question is generally asked is about this atypical pseudocholine esterase treatment. Suppose the patient undergoes this scolin apnea, that is, the patient is not coming out of the scolin. This is also one of the reasons for phase 2 block. There is other reasons for phase 2 block also, but yes, this is also one of the reasons for phase 2 block. Now, if the patient is not coming out of scolin apnea, what is the treatment of choice? The treatment of choice in such patients is mechanical ventilation has to be continued, and you can wait. Eventually, the pseudocholine esterase will metabolize your scolin and the patient will come out and recover. But if this is not working, then you can use fresh frozen plasma or plasma pheresis can be used. The first choice of management is your mechanical ventilation, followed by fresh frozen plasma or plasma pheresis. Now, what are the reasons for phase 2 block? Generally, the phase 2 block is seen when the large doses of scolin, around 5 to 7 mg per kg, are given, or a continuous infusion of scolin is given for around 16 minutes. Because of so high dose of scolin, you have desensitization at the level of the receptors, and it starts behaving like your non-depolarizing muscle relaxants, and there is a scolin apnea which is for prolonged period, and such receptors will eventually recover within 24 to 48 hours. And when we talk about the phase 1 block, I've already told you phase 1 block is the depolarization sustained block. And phase 1 block has to be differentiated from the phase 2 block, and this can be done by using your neuromuscular monitoring, because now the phase 2 is going to act in the similar fashion like your non-depolarizing muscle relaxants. There would be fade on top and there will be fade on post-tetanic count. Tetany stimulus will have a fade, right? Okay, a star one again, which is the only test which is not going to differentiate between your depolarizing and non-depolarizing muscle relaxant, and that is your single twitch test, because in a single twitch the decrease in amplitude will be seen in both the classes of drug. Now, moving forward to the complications of scolin. Scolin is going to act on the heart receptors leading to bradycardia. It is bradycardia, and eventually it leads to ventricular arrhythmias also. Scolin is known to cause bradycardia, and that is why if a repeated dose of scolin has to be given, in a case it is given that a repeated dose of scolin is needed, so which drug has to be added? So the drug is an anticholinergic, that is, an atropine or a glycopyrrolate has to be added. Most importantly, atropine has to be added to the scolin before, or you have to be very cautious of the complication of scolin, which generally happens if a high dose or a repeated dose of scolin is given, which is your ventricular bradycardia. Second is fasciculations. I already told you that scolin, being a depolarizing agent, leads to fasciculations, and these fasciculations lead to post-operative muscle soreness or myalgias. Even this is one of the case scenarios which was given, like for example, a 15-year-old girl was given scolin for intraocular surgery followed by post-operative muscle soreness. So which agent is responsible for this? The agent that is responsible for this is scolin because of the fasciculations. Now, is there any way in which these fasciculations can be decreased? Yes, there is. The way to decrease this fasciculation is by priming. Priming or pre-curarization. What does priming means is, priming has two advantages. Actually, what priming means is that suppose you have to give a non-depolarizing muscle relaxant to the patient. I'll just tell you that non-depolarizing muscle relaxants have an intermediate onset of action. They have 3 to 5 minutes of onset of action. So what we do is we give 1/10 of the dose of NDMRs followed by your IV induction agent. Okay, we give 1/10 dose of NDMRs, and then after giving this dose, what you give is your IV anesthetic agent followed by your scolin. This helps to decrease the fasciculations which are produced by scolin. And also it has one more advantage, that now this is going to decrease the onset of action of your NDMRs also. Generally, after giving scolin, we give non-depolarizing muscle relaxant also, but being an intermediate duration of action, the duration of action is around 5 minutes. But if you have primed the patient before, then the duration of action also decreases to 60 to 90 seconds. So in case you have to decrease the fasciculations produced by scolin, kindly prime the patient, or pre-curarization of the patient is done using 1/10 of the dose of non-depolarizing muscle relaxant. And the second way is prostaglandin inhibitors. Your lysine acetyl salicylate can be used to decrease these fasciculations. But generally, in practical use, it is pre-curarization that we all use. And theoretically, yes, prostaglandin inhibitors can also be used. Then, scolin is known to increase all the pressures in the body. Your intracranial pressures, your intraocular pressures, eventually your intragastric pressures also. That is why scolin is contraindicated in open eye surgeries or glaucoma surgeries, because it leads to increase in your intraocular pressures. Scolin leads to histamine release in the body, leading to bronchospasms and urticarias. The urticarias and bronchospasm which are seen in scolin is because of the release of histamine. It is Yes, it leads to malignant hyperthermias. I've discussed malignant hyperthermias in my previous classes. Scolin and your halogenated inhalational agents, if you'll remember, make the patient highly susceptible to your malignant hyperthermias. A quick revision. Okay, fine. See, malignant hyperthermias are generally caused because of your abnormal calcium ryanodine receptors, and when something which primes the patient for malignant hyperthermia is being given, it aggravates that condition and lots of calcium is released in the body, which eventually leads to your masseter spasms and a lot of hyperkalemia in the body, finally leading to your cardiac arrest or cardiac arrhythmias and problems. This is the malignant hyperthermias, and eventually scolin is supposed to be making the patient highly susceptible to your malignant hyperthermias, which also lead to your masseter spasm. Phase 2 block I've already explained. And one more condition that scolin causes in our body is of hyperkalemia. Scolin, if one dose of scolin is given, it is going to increase the potassium levels by 0.5 milliequivalents per ml. Okay, and why does it lead to hyperkalemia is because we have certain extra junctional receptors which are present in our body. And when scolin is given, these extra junctional receptors get activated and lead to release of the potassium in the blood, and eventually you have increase in the potassium. That is why scolin is always contraindicated in those patients who have hyperkalemia. This is also one of the cases of RSI. If suppose a case comes, for example, a patient needs RSI, but the potassium level are very high, the drug of choice in such cases is also rocuronium and not scoline, because scoline leads to hyperkalemia. Now, these are certain conditions which increase the susceptibility of hyperkalemia in patients who have been given scoline. Most important of them is your burns. About burns, always remember one thing. When we talk about the burn injury, it is always safe to give scoline within 24 hours. Okay, because after 24 hours you have extra junction receptors which start to get activated and eventually leads to increase in potassium. Thus, in burn patient you can give scoline within 24 hours. After that, for around 1 year. Nowadays it is just 1 year. For 1 year, no scoline has to be given to the patient because of the susceptibility to hyperkalemia. I repeat again, if question states within 24 hours, scoline can be given. But after that, for 1 year, scoline should not be given. Massive trauma, again hyperkalemia. Intra-abdominal infection can also make the patient more susceptible to hyperkalemia. Your stroke, encephalitis, spinal cord injury, tetanus, polyneuropathy, hemorrhagic shock with metabolic acidosis, and myopathies and muscular dystrophies. Talking about myopathies and muscular dystrophies, there is one case scenario that comes as of Duchenne's muscular dystrophy. One of the reasons that why scoline is avoided in patients less than 8 years of age. If by any chance such patient has an undiagnosed muscular dystrophy like Duchenne's, that will make patients susceptible to hyperkalemia and eventually leading to cardiac arrhythmias and cardiac death. That is why scoline always has to be given very judiciously in pediatric age group because of the undiagnosed muscular dystrophies like Duchenne's. The contraindications to scoline: hyperkalemia, one thing that we have already understood. ICP increased, I told you. Open eye injuries, your glaucoma, again because of the increase in IOP. Everything that can trigger a phase 2 block, it's contraindicated, like prolonged infusion of scoline or repeated doses of scoline, or if need be that you have to give a very high dose of scoline. Myotonia dystrophica, the patient is a known case of malignant hyperthermia. Children less than 8 years, please don't give scoline if not required. Burn patients, I told you, you have extra junctional receptors. Advanced liver failure and sepsis patients, again because of the danger of hyperkalemia in this patient. And yes, it has to be avoided in newborns because of the one of the same reasons that newborn babies also have extra junctional receptors which are very activated, and eventually it can lead to increase in the potassium levels causing hyperkalemia, which can be life threatening to these newborns. Now coming over, I just hope the part of the scoline is over and most of the questions come from the scoline, especially the mechanism of action, the phase 2 block, your Dubochet number, and the contraindications and the complications which are related to scoline, and eventually your pseudocholine esterase enzyme also. Coming to non-depolarizing muscle relaxants, they are also known by the name of curares. They are competitive antagonists. They bind to the alpha subunit of your pentameric acetylcholine receptors, generally the nicotinic receptors. The NDMRs can be classified according to the chemical structure. We have aminosteroids, we have benzyl isoquinolones, further divided into according to the onset of action: long durations, intermediate duration, and short duration. The long duration, they act for a longer period like 60 to 90 minutes, intermediate duration 45 to 60 minutes, and short duration around 10 to 20 minutes. Talking about the one of the most important muscle relaxant that you all have to remember is your vecuronium and rocuronium, atracurium, cisatracurium. They all belong to intermediate duration of action, out of which vecuronium, rocuronium are aminosteroids. I know it's a bit confusion and it can be a bit boring too, but yes, you all have to revise them again and again so as to memorize them and to fit them in your brain tissues. You have to do that. So aminosteroids are vecuronium, rocuronium, pancuronium, and pipicuronium. Whereas benzyl isoquinones, one of the most important ones, the very first skeletal muscle relaxant that was launched, that is D-tuberculare. Then your atracurium, cisatracurium. The beauty of benzyl isoquinones is it has the longest duration, doxacurium, and the shortest one, gantacurium, both under its heading. We have doxacurium, which is the longest acting, and gantacurium, which is the shortest acting NDMRs. Okay. Here we are not talking about scolin. We are talking only about the subclass of NDMR drugs. What are the goals of giving these NDMRs? Of course, muscle paralysis. When we talk about muscle paralysis, I just want to have a quick recapitulation of the sequence in which the muscle were being blocked. Please always remember your central muscles and their peripheral muscles. Your central muscles include your pharyngeal, laryngeal, and diaphragm muscles, whereas your peripheral muscles include your limb muscles. Your central muscles like diaphragm, they are always resistant to your neuromuscular blockers, but they are always faster in onset because of the blood supply to these areas is very high, and the propensity or the number of the receptors that are present in these muscles is also very high. That is why the diaphragm muscles are the very first muscles that get paralyzed. Eventually, last muscles to get paralyzed are your limb muscles or adductor pollicis muscles. This is how they get paralyzed. The first is the diaphragm and eventually your peripheral muscles, and in between comes your pharyngeal, laryngeal, and orbicularis oculi muscles. Talking about recovery from paralysis is always in the opposite direction to the sequence of the muscle blockade. Your upper airway muscles are always extremely sensitive. Okay. Please remember one thing, that your upper airway, pharyngeal and laryngeal muscles are very sensitive and they can go into dynamic obstruction at the time of extubation, even if your TOF ratio is coming more than 0.9. That is the main reason it has been made compulsory during your extubation or as a part of your recovery profile. Your TOF ratio should always be more than 0.9 when you are extubating this patient. Always remember this. This is asked multiple of times, that the TOF ratio has to be more than 0.9 so that we can be confident enough that your upper airway muscles have recovered from the paralysis. Talking about the ED95 of your neuromuscular blocking agents, the ED95 effective dose 95. This is the most effective dose which shows a muscle paralysis in 95% of the patients. That is your ED95. Talking about the recovery index from your neuromuscular blocking agents, that is, when we were talking about the neuromuscular monitoring, we knew that twitch heights that were coming in TOF or your PTC, this is how the twitch heights were coming. I just request you all, if you don't remember, so please go to the neuromuscular monitoring class again, because repetition of this is not possible in detail here right now. When we talk about the recovery index, it is 25 to 75% of your twitch height. When 25 to 75% of the twitch height comes back, it means the patient has started recovering from the effect of your neuromuscular blocking agent. Now, lastly, the question that comes is the neuromuscular blocking agents, different agents have different cardiac effects also. As we will be dealing with one drug each, you will be able to see that there are certain drugs which are vagolytic in nature. This is because, or there are certain drugs which cause tachycardias. This is because of one or two mechanisms. First one is the histamine release. Some of your neuromuscular blocking drugs will lead to histamine release. Please remember, when we come to the drugs, you all have to remember which drug is going to lead to histamine release. And second is that certain drugs act on your muscarinic autonomic receptors or your autonomic nicotinic receptors and your cardiac muscarinic receptors, leading to tachycardias. I repeat, the three mechanisms of action for the cardiac effects of neuromuscular blocking agents are histamine release, autonomic nicotinic receptors get activated, and cardiac muscarinic receptors get activated. Now moving to fun drug at one time, pancuronium. Pancuronium is a aminosteroid, long acting. See, when we will be talking about individual drugs, I'm not going to tell you about the whole details of the pharmacokinetics and dynamics of the drug, because it's not practically feasible to remember each and every point about that drug, right? What I'll be telling you is about the salient features of the drug which have been asked, or yes, potentially which can be asked. Pancuronium is aminosteroid, which is a long-acting drug. The most important thing about pancuronium is that it is sympathetomimetic. It is vagolytic. It leads to increase in heart rate and increase in blood pressure. It's not cardiac stable at all. That is why pancuronium is avoided in all those cases in which we don't need tachycardias. For example, in patients of mitral stenosis. Never give pancuronium in such patients because it leads to tachycardia. But the beauty of pancuronium is it's a very, very good bronchodilator. It does not lead to histamine release, and it is the drug of choice in asthmatic patients. Actually, these days, pancuronium is not too much used because of the introduction of inhalational agents, which are very good bronchodilators. But if asked that which is the best drug of choice in muscle relaxants for asthmatic patient, it is still pancuronium that remains because it's an excellent bronchodilator. It gets renally excreted, contraindicated in renal and liver failures. Daycare surgeries, of course, you cannot give it because it's a long duration drug. Hypertensive patients or the patients in which tachycardia or BP should not be increased, pancuronium is again contraindicated. But one of the conditions in which pancuronium can be used is mitral regurgitation. Sometimes your side effects become beneficial for certain conditions. This is how pancuronium also works. In mitral stenosis, if you remember the pathophysiology of mitral stenosis, yes, I'm not going to discuss it here. In mitral stenosis, you don't need tachycardias. But when we talk about mitral regurgitations, you need tachycardias in those patients for which pancuronium could be useful. Moving to the most commonly used skeletal muscle relaxant, that is vecuronium. Please remember one thing, vecuronium is not stable at room temperature. Thus, it is available in a lyophilized powder form and you have to reconstitute the vecuronium. It is an intermediate onset around 3 to 5 minutes. The dose is 0.08 to 0.1 mg per kg. intermediate duration of action around 25 to 30 minutes. But when it gets metabolized, it is hepatic metabolism, and most of the vecuronium is released in or excreted in the bile. It has an active metabolite. 3-desacetyl vecuronium is the active metabolite of vecuronium, and it has a potency of 60%. Thus, no infusion of vecuronium is given because eventually it leads to polyneuropathy. That is why vecuronium is avoided for long infusions, as it has an active metabolite which has around 60% of its potency of 3-desacetyl vecuronium. Excreted through renal, it is cardiostable. Vecuronium is a cardiostable drug. It's a cardiostable drug. No histamine release, no vagolytic action, no hemodynamic changes, no pain on injection, and is the most common drug which is used in the operating theaters for maintenance, not for long duration of infusions but for maintenance. Then it is contraindicated in liver failures. The reversal is your neostigmine or your sugammadex. Both can be used to reverse your vecuronium. It is the drug of choice in your cardiac surgeries, in your neurosurgeries, because it is cardiostable. But vecuronium is not given in cases of anticipated difficult intubation because of its intermediate duration of action. Moving forwards to rocuronium. I've already told you one of the conditions in which rocuronium is used, that is your RSI, rapid sequence intubation. If colon is contraindicated, then this is the drug of choice, that is rocuronium. It has fast duration of action, 60 to 90 seconds, depending upon the dose actually. Its action is dose dependent. Rocuronium's action is dose dependent. If given at a higher dose, the onset will be faster. Intermediate duration, that is why we don't prefer giving it in difficult intubations. It is the drug of choice for continuous infusions if needed because it does not have any metabolites. I repeat, this drug is preferred for continuous infusions because it does not give any metabolites. It is excreted through bile, and generally there is very less accumulation in renal and hepatic failure. Rocuronium is also not cardiac stable and not recommended in cardiac surgeries. The problem with rocuronium is majorly it has pain on injection. It is a painful agent. Rocuronium is a painful agent. Yes, my next question is the IV induction agents which can lead to pain. Your methotrexate can lead to pain, your propofol can lead to pain, your etomidate can lead to pain, and eventually your rocuronium also leads to pain. Metho, propofol, please go and revise the class again. Etomidate and rocuronium. They all can lead to pain on injection. Reversal agents, again the same, anticholinesterases and your sugammadex. Sugammadex per se was made for rocuronium. Sugammadex was actually made for the rocuroniums. Moving forward to etracurium. See, etracurium is a racemic mixture of cis and trans etra. Onset is moderate, 3 to 5 minutes, intermediate duration of action. The beauty of this etracurium drug was that it gets metabolized by Hoffman degradation. If you see the Hoffman degradation, it is a non-enzymatic and non-organ dependent. Non-organ dependent degradation of the drug at the physiological pH and temperature. That is why it is the agent of choice in renal failures and liver failure patients because it is degraded through Hoffman degradation, which is not dependent on any organ. But the problem with atracurium is it leads to release of histamine, thus causing bronchospasm, hypotension, and tachycardias also. And it has to be avoided in asthmatics. It is not vagolytic, but it can lead to peripheral vasodilation, leading to reflex tachycardias. Atracurium has one metabolite, that is laudanocin. Laudanocin is toxic, especially in renal failures, and can lead to your seizure-like activity. It can lead to seizure-like activity. Laudanocin. Cardiac, it is not stable. I've already told you, scolin, bradycardia, rocuronium, vagolytic, pancuronium, vagolytic, atracurium, because of its histamine release, it's not cardiac stable, and eventually vecuronium, which is cardiac stable drug. Atracurium is not stable at room temperature and it gets degraded very fast, and thus atracurium should always be stored in refrigerators at a temperature of 4 degrees Celsius and pH of 4, because at physiological pH the Hoffman degradation of atracurium will start. Now, when atracurium was being produced, now a congener of atracurium has been introduced by the name of cis-atracurium. Now, the special thing about cis-atracurium is moderately rapid, same, but the degradation is only by Hoffman. If you had seen in the previous slide, atracurium got degraded by two mechanisms. 95% was Hoffman, but still 5% it was Astor hydrolysis, whereas in cis-atracurium it is only Hoffman. The special thing about cis-atracurium is it does not lead to histamine release and no risk of laudanocin toxicity, and most importantly, it is more potent than atracurium. Cis-atracurium is much more potent than atracurium. Please remember this. Cis-atracurium has no histamine, no laudanocin, and it is more potent than atracurium. The uses: extremes of age, pediatric, geriatric, we prefer these two drugs. Renal hepatic failure in pregnancy, in patients who have a known hypersensitivity of neostigmine also, because if we don't want to give neostigmine, then atracurium, cis-atracurium are drug of choice because they get degraded by Hoffman elimination, and thus for reversal purposes they don't need a neostigmine. The duration of action is never prolonged on infusions, and thus they are also preferred and quite suitable for patients on mechanical ventilations in ICU, because in ICU, of course, the patients are very sick, they are ill, their renal, liver, multi-organ failures can be there, and cis-atracurium is very safe in renal and liver failure patients. Now, talking about a very, very important concept and 5-star question, that is the histamine release that I was talking about. See, the histamine release of atracurium can be decreased. Actually, cis-atracurium is quite an expensive drug. So, if you can decrease the release of histamine, so maybe atracurium can be used in a lot number of cases. So, histamine release can be reduced by two. One, decrease the speed of giving the atracurium to 75 seconds. That is, the atracurium should be given slowly and slowly in around 75 seconds. And secondly, give prior some H1 or H2 blockers to the patient so that histamine does not get released from the body. That was simple. Talking about mevacurium. Mevacurium is one of the shortest acting, only 10 minutes duration of action mevacurium has. That is why it is the drug of choice for daycare surgeries, and it is the only NDMR which is metabolized by pseudocholinesterases. Rest all are either excreted in the bile, or Hoffman degradation is there, or ester hydrolysis is there. But when we talk about pseudocholine esterase, the same enzyme that was degrading your choline, mevacurium is also degraded by pseudocholine esterases. Mevacurium releases a lot of histamine, but still it can be considered as the drug of choice for daycare surgeries because of its shortest duration of action. Coming to Gantacurium, I told you to please remember this Gantacurium mnemonic. I think I told you 4304 earlier. I'm extremely sorry for that. It is 430A, and this is asked. AV430A. For this, you have to revise it again and again. That's Gantacurium. Gantacurium is a newly introduced neuromuscular agent which belongs to the class of mixed onium chlorofumates, and it has ultra short acting, only 8 to 10 minutes duration of action it is chlorofumate. And the beauty of this is the metabolism. It is metabolized using cysteine adduction. L-cysteine is used to metabolize your Gantacurium. The onset is also very fast, 40 to 50 seconds. The onset, ultra short acting, like scolin. It is more or less working like scolin only, but yes, it is not used in so much practice right now like scolin, and much trials have to be conducted such that it can be introduced into the market as popularly as scolin is being used. But this is one of the non-depolarizing muscle relaxants which is acting in the similar fashion of onset and duration like your succinylcholine. Coming to certain part of the history, D-tubicurarine. D-tubicurarine, the very first agent to be introduced. The two important things about that you all have to remember is it leads to the maximum increase of histamine, and secondly, is the only drug that can lead to the block. The ganglion block was seen by D-tubicurare, leading to hypotension. The reason for hypotension using this was ganglion block. I already told you D-tubicurare is a muscle relaxant, the arrow poison which was used by hunters. They produced it from a bark of a tree, and they used it to hunt the animals. Second is peppercoronium. It's an old agent with no vagolytic activity. Then there was rapacuronium. Questions are asked on rapacuronium that why it was stopped, because it has a very fast onset of 75 seconds, but because of the unopposed actions on the muscarinic receptors, it led to very intense bronchospasm, because of which eventually it had to be taken out of the market, in spite of the fact that an NDMR who had such a fast onset of action. Lastly, we have galamine. Galamine, all these non-depolarizing muscle relaxants are generally quaternary compounds which do not cross placenta. But galamine is the only NDMR which eventually crosses your placenta, and it can lead to your vagal block also. It is contraindicated in renal failure and pregnancy. See, these four drugs are only for historical purposes and for certain MCQs which are asked out of these drugs. Like for rapacurium, it is your bronchospasm. For galamine, it crosses your placenta. Doxacurium. Doxacurium is the longest acting drug. It is the longest acting NDMR. The shortest acting NDMR is your Gantacurium, and longest acting NDMR is your Doxacurium. Should I repeat it again? The shortest acting is Gantacurium. The longest acting is Doxacurium. It is highly potent, renally excreted, and there is no histamine release when we talk about Doxacurium, but still not used much practically. Alcuronium was known for its anaphylaxis and thus not used. And lastly, we have mitocurin, again for historical purpose. It was a semi-synthetic derivative of D-tuberculare with less serious side effect in comparison to D-tuberculare. I hope you still remember the side effects of D-tuberculare. They were massive histamine release and the only NDMR which was known to cause the ganglion block leading to hypotension. Coming to a quick revision, when we talk about the day-care surgeries, rocuronium plus sugammadex can be used much into because sugammadex and rocuronium, their onset and the duration are good, plus they are cardiac stable. I mean to say the cardiac stability is like minimally they can be vagolytic, but histamine release is very less in comparison to mivacurium, which has a shorter duration of action, but still the histamine release by mivacurium is quite high. Then you can have cis etracurium, rocuronium plus neostigmine. So the first choice for daycare surgeries will always be a combination of rocuronium plus the reversal agent sugammadex. I'll tell you a little about sugammadex later. Second will be mivacurium. But if not given anything, then the drug of choice for the daycare surgeries will be your mivacurium. Is that clear? If mivacurium is in the option, the first choice is always mivacurium. But if the option states rocuronium plus sugammadex as a whole, then the first choice becomes your rocuronium plus sugammadex. Let's be very clear on this point. Histamine release maximum D tuberculare followed by atracurium and mivacurium. Drugs which are metabolized by pseudocholine esterases. Two you have read in this very chapter, scolin and your mivacurium. And the other are your local anesthetics, aster local anesthetics. Even they are metabolized by your pseudocholine esterase enzyme. Now moving to yet another very important concept, but very practical and a common sense concept, like what are the factors which can lead to prolongation of the action of your neuromuscular blocking drugs. Obviously, any extremes: elderly, pediatric, obese patients, renal failure, hepatic failure patients in which the metabolism or the excretion of the drug is compromised. Then your inhalational anesthetics. Your inhalational anesthetics are actually membrane stabilizers. They also decrease the muscle tone. Then eventually they are going to potentiate the action of your neuromuscular blocking agents. Similarly goes with your local anesthetics. Your local anesthetics are also membrane stabilizers. They are also going to potentiate the action. Then dentrally, it's a peripheral muscle relaxant. Hypothermia. In hypothermias, your metabolism gets decreased. Certain antibiotics. This is something that you have to remember. Antibiotics. There are three class of antibiotics: aminoglycosides, tetracyclines, polypeptides. Your ATP. Aminoglycosides, tetracyclines, polypeptides, which are known to decrease the release of acetylcholine and thus prolong the action of your drugs. Your anti-arrhythmic drugs like quinidine, lidocaine, and a very important and interesting case scenario that comes a lot of times is of this: CA bronchus. Sometimes the question comes in the form that the patient has been posted for a surgery and is a known case of CA bronchus, and there is a prolongation of the effect of muscle relaxant. So what is the monitor of choice? Or what is the reason of this prolongation of action? So the reason behind this is myasthenic syndrome, which leads to the prolongation of the action of your neuromuscular relaxants in these patients. And the monitoring of choice is your neuromuscular monitoring. Remember, in CA bronchus patient, they have a syndrome which is mimicking your myasthenia gravis. That is your myasthenic syndrome, leading to prolongation of the action of the drugs. Then local anesthetics, calcium channel blockers. Calcium is required for the propagation of the action potential. Hypocalcemia, hypokalemia. Potassium is also required for the muscle action potential generation. Magnesium increase in magnesium. Hypermagnesemia leads to potentiation of your NDMRs. Please remember, when we talk about magnesium, it is hypermagnesemias. Then lithium, furosemide, cyclosporine, acidosis lead to increase in the activity, and your certain neuromuscular diseases. They all can potentiate the action of neuromuscular agents. Out of this, the most important is your renal organ failures, your antibiotics, hypothermias, and your electrolytes. These are the most important things that you all have to remember for prolongation of the action. Now, there are certain factors which can lead to shortening of the block also. Again, common sense. Anything that is going to that's going to increase the activity of your liver enzymes is eventually going to increase the metabolism of your muscle relaxants. So, your anti-epileptics, phenytoin, carbamazepine, your calcium, of course, burns and hemiplegias. These are the two conditions in which you have certain extra junctional receptors that are being produced, and it increases the activity of your acetylcholine. And yes, it is something like in dilemma whether it leads to shortening of block or not, but still people consider them one of the factors of shortening the block of the neuromuscular agents. The most important them is anti-epileptic drugs and your calcium. All right. Talking about the potassium, see, potassium is generally intracellular cation, but when we talk about the nerve potential, whenever we have an action potential that is coming, your sodium potassium ATPase pump gets activated, and you have 3 sodium that comes in and 2 potassium that comes out. So potassium plays a very important role as an intracellular cation for the propagation of your action potential. So please remember, when we talk about hypokalemia, that it is decrease in the potassium in the blood or in the plasma per se, you have a state of hyperpolarization in which the person is resistant to the action of your depolarizing neuromuscular block. Because neuromuscular block depolarization, the depolarizing neuromuscular block act like your normal acetylcholine. So if we have hyperpolarization, there will be resistance to that, but increased sensitivity to non-depolarization muscle block is seen. And vice versa happens when we talk about hyperkalemia. When there is hyperkalemia, then we have depolarization of the membrane, and there is an increased effect of your depolarization neuromuscular blocker and oppose the effect of non-depolarizing muscle blocker, right? If potassium is less, we have hyperpolarization leading to the resistance to the depolarization neuromuscular block and increase in the sensitivity of the non-depolarizing neuromuscular block, and vice versa happens when we talk about hyperkalemia. Now coming just in brief about the reversal of the block, we have two kinds of agents. We have acetylcholinesterase inhibitors first, which are indirectly acting. What they do is actually they increase the acetylcholine in the synaptic cleft by inhibiting the enzyme acetylcholine esterase. And these are your neostigmin, pyridostigmin, and hydrophonium. These are the 3 agents which are most commonly used for reversal of your neuromuscular blockers. Neostigmin is used in the form of 50 to 70 microgram per kg, but the star question for neostigmin that comes is it is also used for paralytic ileus. One of the conditions where neostigmin is also used is your paralytic ileus. Talking about pyridostigmin, not much in used, but yes, it is used in cases of myasthenia gravis for treatment. Hydrophonium See, hydrophonium, when we talk about, it is actually one of the agent of choice which is used when we talk about phase 1 and phase 2 block. Yeah. When we have to see that swollen phase, that whether the patient is in phase 1 block or in phase 2 block, then we use hydrophonium, because I've already told you that neostigmine per se potentiates the action of scolen. So hydrophonium is the agent which is used to diagnose between phase 1 and phase 2 block. Okay, and it does not interact with pseudocholine esterases like your neostigmine. Hydrophonium is also the reversal agent for mivacurium. When we talk about mivacurium, hydrophonium is used for it. When we talk about vecuronium, it is neostigmine. When we talk about atracurium and cisatracurium, they don't require anything. And we talk about rocuronium, the reversal of choice for rocuronium is your Sugama dex. Talking about Sugamadex, it is a direct acting reversal agent. By direct acting reversal agent, I mean that this is the Sugamadex, that is cyclodextrin. It takes the muscle relaxant into it, forms a complex, and the whole complex get excreted in the renal. Okay, this is how Sugamadex works. It's a cyclodextrin. It forms the covalent bonds with your skeletal muscle relaxants, and a complex is formed, and the whole complex is taken and then excreted in renal. Sugamadex had been formed for rocuronium, and second choice is vecuronium. It is only meant for aminosteroids group. Always remember, Sugamadex was meant only for aminosteroid groups and not for benzyl isoquinones. Okay. Talking about the last, calabadoin. Calabadoin is a directly acting reversal agent recently introduced. Yes, it has been seen that it works on your depolarizing muscle relaxants also, and also on your aminosteroids as well as your benzyl isoquinones. Talking about the anticholinergic use in reversals. Neostigmine is known for its effects on heart leading to bradycardia. That is, your muscarinic receptors are activated leading to bradycardias, for which neostigmine should always be given with glycopyrrolate, whereas hydrophonium is always given along with atropine. This is something which is based upon the onset and the duration of action, that neostigmine is always combined with glycopyrrolate and hydrophonium should always be combined with atropine. Yeah, talking about Sugamadex. See, when we talk about Sugamadex, one thing is that it has recently introduced, and second is that it is still on trial basis whether anticholinergic should be added or not. Many of the people say no anticholinergics should be introduced along with Sugamadex, but yes, recently one or two articles have been published. So, talking about Sugamadex, for you all, no anticholinergics are required still. Signs of adequate reversal. It's just a quick recapitulation of our previous class. If you all remember, it is TOF more than 0.9, and the nerve or the muscle is adductor pollicis muscle or the ulnar nerve that had to be checked. Indirect signs are your 5-second head lift, 5-second leg lift, hand grip, positive tongue depressor test, and eventually if your inspiratory pressure is maintained to -40 to -50. This is your pressure that you can maintain. Now, there are certain case scenarios. This is the very last part of this discussion. For example, I already told a 15-year-old posted given schooling followed by fasciculations and is now complaining of post-operative soreness. What is the mechanism of action? depolarizing block. Talking about the neuromuscular monitoring, a lot of questions are asked like fade phenomena is seen in depolarization blocks, in phase 2 blocks, in non-depolarizing muscle relaxants, and in which it is not seen. Then atracurum given to a patient leading to flushing, tachycardias, and hypotension. Mechanism, histamine release. Burn patient. Again, scoline can be given till 24 hours and not to be given after 24 hours to 1 year. So drug of choice becomes your vecuronium or your rocuronium. Scoline apnea treatment I've already told you about. Mechanical ventilation is the first choice, followed by FFPs and plasmapheresis. And always remember, myasthenia gravis patients, they are resistant to your depolarizing muscle blocks but sensitive to your non-depolarizing muscle block. I always told you we all have to have an edge over the others. So that's the edge. Myasthenia gravis patients, they are resistant to your depolarizing muscle blockers, whereas they are sensitive to your non-depolarizing muscle blockers. Thank you.